It is my pleasure, privilege, and honor to welcome our panelists. The power that be have instructed me not to go over the bio, but I will really encourage you to read and inform yourself about our amazing panelists. Where I come from, when you get a doctorate, we usually call you an institution. So these people are institutions in their respective field. So with, without further ado, allow me to welcome our panelist, Dr. Josey. Please put a hand of applause for them. Awesome.
Well, way to Hold on, stay there.
First of all, destroy you. Yes.
Next, Dr. Bonds. Please put your hands together for Dr. Bonds.
But she was quoted in the New York Times.
Next on our list is Dr. Lara. Please put your hands together for her. CEO. Last but not least, Dr. Husband. So if we ask them to fully give us an introduction about themselves, we are not going to leave here today. So we are going to ask them to give us a snippet of who they are, their practice, where they are practicing, and their location. Just summary, concise. Thank you.
Good morning, everyone. I'm Dr. LaKeetra Josey. I'm a psych nurse practitioner and president of our Minority Fellowship Graduate Association, of which our recent graduates will now become members. Thank you. You notice you will become members. I was a PhD fellow of a few years ago. We're just going to leave it at that. So I was a doctoral fellow. I graduated from the University of Pennsylvania. I used to be the associate program director of the Psych NP program there. I currently have an outpatient practice, an outpatient mental health practice in Wilmington, Delaware called Your Center. A substance abuse treatment program called Phoenix Center for Health and Wellness, and more recently we have expanded to providing services to U.S. veterans in the Dominican Republic through the Foreign Medical Program. And so we're expanding international in order to provide service to our U.S. vets that are struggling. So that is some of our work. Thinking to the list of questions that we had, one of the questions that I would ask and that I would ask our panelists to kind of speak to briefly is, what was like one piece of advice that you got during your time in your program or when you graduated that you found most helpful to you? So I'm going to give you two pieces. One was a psychiatrist that I was working with said just because somebody wants something doesn't mean that it's the right thing for them. And I think sometimes as nurses and as nurse practitioners and as clinicians and even as faculty and professors, we want to be, like we're in a helping profession, right? We want to help people feel better. So knowing that, but also knowing that sometimes the thing that somebody wants the most might be the thing that's the most detrimental to them. So being okay with saying no. And then the other thing was, I have to quote it properly, but failure to plan on your part does not constitute an emergency on mine. And so the reality was, and what my preceptor was trying to tell me at that time was like, I needed to understand what boundaries were. I needed to understand that like I didn't have to be everything to all people at all times. And that sometimes we needed to let people experience what it means to have to plan and to plan appropriately. So those were two things that were very helpful to me in not only in practice, but also in transitioning into some of the things that I've done.
Morning, everybody. My
Good
name
morning.
is Dawn Bounds. I'm an assistant professor at the University of California in Irvine. And I am also on the NAC. So one of the folks that reviewed applications when you all came in. And also an alumni of the program. I'm a psych mental health nurse practitioner, and I was a doctoral fellow in the PhD program. Again, a while ago. I was just reminiscing with Dr. Gary and Dr. Urande about my first intensive a while ago. And so I got my PhD at Rush University in Chicago, and I have worked as a psych mental health nurse practitioner in academic practice, which included working in school-based health centers on the west side of Chicago, as well as homeless shelters on the west side and north side of Chicago. I also have worked in private hospitals, so partial hospitalization programs, intensive outpatient programs, outpatient programs, and I've also worked in Cook County Juvenile Detention Center, and so that was like a private contract through another organization back when Cook County had a federal mandate to develop mental health services in the Cook County Juvenile Detention Center. In addition to that, I had a private practice. And in California, when I first started, I left Chicago, went to California to join a tenured track. And I also had an academic practice there for a little bit. I closed all of that over the last couple of years to focus on my research. So I'm not currently practicing, but as you have heard, I've had various experiences practicing as a nurse practitioner. In terms of advice I received, I think one of the things that I remember one of my mentors, who was a child and adolescent psychiatrist, sharing with me is that solo practice can be isolating. So if you are in practice all by yourself and you are someone that needs some stimulation and collegiality and, interaction with other folks other than your patients, you might decide to complement that solo practice with other things. So he actually didn't need the money, but used to come to Partial and work with me in Partial because his private practice all by himself was really isolating. So that's something that stuck with me. You need to know yourself and know what keeps you going. And if being all by yourself all the time ain't it for you, you might really need to plan accordingly to decide what you want your life and your practice to look like.
Good morning, everybody. I'm Daisy Lara. I am double board certified nurse practitioner, family, as well as psychiatric mental health. I'm an entrepreneur. I consider myself an innovator, and I'm also a mother. That's a huge job. I own 2 practices in downtown. It's in Pennsylvania. One practice is focused on mental health, and the other one is it's focused on more of gut health and how nutrition can affect mental health. So that's kind of what I'm trying to work on with my clients. I've worked in different areas in intensive IOP, PHP programs with dual diagnosis patients, eating disorders and substance use. Also inpatient. A lot of my patient population are Spanish speaking and adolescents with high risk teens. So what else?
When you can.
My piece of advice. So be confident, be competent, and like Dr. Josey said, is learn how to say no. That's gonna be huge. Set boundaries. Like she said, what people want and not always what, and you know what's right and wrong. So stick to it. And I'm the immediate past president of the National Association of Hispanic Nurses Philadelphia chapter.
So, hello everyone, my name is Dr. Shelby Husband. I'm a recent graduate of University of Tennessee Health Science Center in Memphis. I'm also a DNP alumni MFGA of last year, so I'm grateful to be invited back to come spend some more time with you all. As far as where I work at integrated addiction care. So of course we see people with substance abuse issues and prescribe medication for them and medication management. I also work at an outpatient practice via telehealth through Dr. Schrock. She's not here today, but through her practice in Colorado, which is a full practice state as well. A piece of advice that kind of what Dr. Daisy was saying is that my preceptor told me before I left, she was an amazing preceptor. I was honored to really practice under her because she really spoke into my soul, not just as a student, but just as a person, just as a man. So she told me, be confident in who you are, be confident in what you know, and whenever you walk into a room, own it, own what you know. And if you don't know something, that's perfectly okay, but just know where to go find the answer. But never let anyone shake you or make you feel like you're incompetent or you don't belong where you're going, because you do. Sometimes we walk into these rooms and we have more experience than the people that we're reporting to. So don't forget that. I just wanted to share that one piece of advice with you all.
Thank you. Yeah.
Wherever you would like to be, my love. Is this one on? Okay. Clicker. Don't mind me. I'm not very tech savvy. I was more focused on like, is the font the right size? Is there an extra period? Forgive me for typos or any of that stuff. But just to give you an idea of the way we have this presentation set up. So again, you see us, who we are. You can read our bios in our pamphlets and everything. What we wanted to do, we want this to be as interactive as it possibly can be. But there's a bit of information that we want to give you up front, just like a place to start, because sometimes I feel like even though we said, ask us your questions, as we start talking, we know that more questions are going to come up because, someone may think of something and that's going to trickle into something else. And so we want to have as much time to be able to do this. So our timing from a schedule standpoint might be a little bit different, where we're going to go through some content and then maybe take say personal needs break. So like restroom, grab a beverage, come on back, so that we can really get into having these discussions, answering the questions that we have to the degree that we can. I would also just recognize that everybody in here is in a different space in their process. Some people are finished their program, some people are just starting. So some stuff may not be immediately applicable to you, but it could be in the future, or it could be applicable to somebody that you know, and you may be able to be a resource for them. So it's not just about us, right? It's about helping other people in their path and their journey too. But just to give you an idea, the way that we essentially thought about this is session 1 is kind of our practical next steps. Finishing my program, what am I doing now? And then session 2 is really where we're going to dig into different models of practice, interviewing and contract negotiations. Yes, it is possible to negotiate things that go into your contract and things that don't. Psychological and physiological safety. So being okay in the space that you're in and what we do and how we do that, how we protect ourselves, because that is very important. And really anything else that we have time to get to this morning. That's our plan. So just practical next steps. ANCC certification, right? So if we finish the program and we're going to be a nurse practitioner, we are required to be board certified in most states, with the exception of New York and California, I believe it is right now, that do not require board certification for as a psych NP. So if you're practicing in those states, it's okay to get licensed. Just know that going to another state, even though you had a license or have a license in maybe New York or California, you will be required to take the test. And you will, in order to get your license. So you won't be able to just transfer directly over. And what I would say to you on that note, and the farther away you get from school, the more that stuff falls out of your brain, and the more the things that actually, so there's the stuff they test you on and answers that you're supposed to give, and then there's the things that happen in real life. We see that in nursing, and then we see that in clinical practice too, right? So we don't want to be so far removed from having that information that we're not able to take the test. And the links will provide these PowerPoint presentations to you. So the links are all here for you to access. I don't want to spend time clicking through the different sites, but just to give you an idea of what they are, one is a link to the certification website, and then one is the link to the site that is specific to the Psych NP certification. And on that, you'll see things like test content outlines and practice questions and things that could be of help to you as you're prepping for your exam. Another practical just next step that people that I think sometimes don't necessarily think about, and I think you guys can speak to this as well, you've got to think about where you're going to be practicing, right? So some people are more mobile than others. Some people, the place that you're in is the place that you're in. You have your family, your kids are in school, your life is set, so you have to work with where you are. Some people, you might be up to picking up and moving and saying, I want to go live in XYZ state, and that's where I want to be. I would advise you, before you pick up and move your life to some new state, make sure that you understand that you'll be able to practice the way that you want to be able to practice when you get there, right? Like, you don't want to pack up and move and go someplace and find out, oh, wait, I actually can't open my own practice unless I have a collaborative physician, and we'll get into that stuff later, but like, if you go and you find out that like you now have to have a collaborative physician, or you have to have two, and now you have to write a check to somebody to be your collaborator in order for you to have your own practice, like, that's going to impact things for you. Some states require you to have a collaborative agreement before you can even get your license. So it's not even about whether you have your own practice. It's about whether or not you can even be licensed as a nurse practitioner. You have to have somebody else sign off to say whether or not you can do that. So those are things that you need to keep in mind when you're thinking about where you're going to go. And if any of this is redundant to you, my apologies, but we don't, like, everybody goes to different programs. Some of this stuff is covered in people's programs. Sometimes this isn't. Show of hands, how many people have had discussions in your programs about where you're going to practice after you get out?
Raise your hand higher.
Raise higher. So that's maybe less than 10, right? How many people have not had any discussion about looking up licensure and scope of practice where you go after you're done?
Raise your hand high.
Higher. Yep. And it's not to make you feel bad. Like, you have no control over your school's curriculum, so it's not to make you feel bad. But this is part of the reason why we talk about these things here. Because we want you to be supported in whatever it is that you're going through. I don't know if I pushed the button. What is this? Let's see if I can minimize that. Okay. So when we're providing this information, as I said, like, some of it will be applicable to you, some of it will be applicable to the person that's sitting next to you. In some way, I would just ask you all to have a learning brain. Keep your mind open so that the stuff can come. I'm good. We're good. Thank you. And I'm like, I figured it out. So just keep your mind open to learning new things. Like, our profession is a profession that is constantly changing. New rules come out, new regs come out, new meds come out. Like, being able to keep all of that stuff in mind, thinking about, do I want to be in clinical practice or do I want to be in an academic setting? What are the rules going to be wherever I am? And another reason why we talk to you or say that that's important is understanding that, like, that is your protection. That's your protection. That's your protection for your license. It's your protection for your liability, because you cannot rely on someone else to know the rules for you. And when it comes down to it, if there's a problem, it is your license, right? It's not the administrator of the hospital that will lose their license. You will be the one that will lose your license if you're doing something that's outside of your scope, something that you're not supposed to do. Not knowing that you weren't supposed to do it will not be a reason to protect you. And I'm sorry to say it that way, but we do believe in honesty, we do believe in transparency, and we want you going into things with your eyes wide open. Not terrified wide open, wide open, knowing that you're supported, okay? Yes? Okay. So these two sites, the American Association of Nurse Practitioners, the State Practice Environment site, and also the National Council of State Boards of Nursing site, both have information about the scope of practice and the state of practice across the country. So they're updated periodically because, like, rules change. So some states are full practice. You can go, you get your license, be a nurse practitioner, open your own place. Other states, they have limited practice, so you have to have an agreement. Some states are completely restricted, so you can't do anything unless someone says it's okay for you to do it. But it varies, so you need to know and you need to look this stuff up, right? So in Colorado, Shelby, what's it like in Colorado?
So in Colorado is a full practice state. So the practice that I'm working with, Strock Medical Group, it's owned by Dr. Strock. So there is no need for an actual physician there. She owns her own practice. Everyone that works there, as far as a medical provider, is an actual NP. So for that state, you don't need a collaborating physician. But the state I'm actually living in, you actually do need one. In the state of Tennessee, it just has to be a physician that works within the practice of, whatever you do. So if you work in psychiatry, it just has to be not necessarily a psychiatrist, at least what they say, that you can collaborate with, but if they have to be working within psychiatry in some type of way. I personally would just recommend, like, if you are in Tennessee and you do need a collaborating physician, get an actual psychiatrist. That would make the most sense versus just getting any MD that works closely with you. And that's just because of lawsuits and things like that. Because if you ask them a question about a certain medication, they advise you on it just based on their understanding, and it's wrong and something happens, it's a very easy question for them to say, well, why didn't you ask a psychiatrist? Why did you just ask someone who specializes in something else but works closely with psychiatry? And then you can't just say, well, they're just my collaborating physician, but what is their actual specialty though? Do they have the same background as you? Do they have the same experience as you? So just be mindful of that. The rules sometimes are kind of vague depending on the state, so you actually have to probably do a little bit more research about what you're planning to do. And then if you don't know, try to go to someone in that same specialty as you.
Daisy?
So I live in Pennsylvania. We need a collaborative, and we have to have a substitute or secondary collaborative as well, which is a huge barrier, by the way. Huge. People don't recognize or realize how hard that is. It's very difficult. Because once you have that one collaborative, trying to find another one, it keeps nurse practitioners from being able to provide care. It's a huge barrier. I have to pay my collaborative every month. She doesn't sign anything. I am the one running my practice, but I have to pay her for being able to do so. So know that, and just like Shelby said, the Board of Nursing is very vague on who to get as your collaborative. They don't specify it has to be a psychiatrist. However, get a psychiatrist to cover yourself.
So both Illinois and California had the requirement of collaborative physicians, and both of those states have moved towards full practice authority. In Illinois, the requirement is a certain amount of hours of practice, and guess who has to sign off on those hours of practice? A physician, yeah. And so there's still that limitation. So that was the negotiating, and that's where they ended up in Illinois. California has still not figured out what it's all gonna look like. So although it passed, they're still working to figure out how they're going to actually put it in practice to get rid of those agreements. So that's the challenge. When we get to a point of full practice authority, there's still this negotiation that occurs to figure out how we are now going to move forward with full practice in each state. And so in Illinois, the physician is the one that's supposed to sign off on those hours. And for somebody like me, as you all heard, I've worked in a variety of settings. Sure, I have those hours, but who's going to sign off on that?
Right. And so I'm in Delaware, and Delaware is a full practice state. For a period of time, you had to have a collaborating physician. And the collaborating physician, before it became a full practice state, I'll say, I've been there and watched the change. But when I first started practicing in Delaware, it was, I had to have a collaborating physician, and my collaborating physician could be a doctor, a DO, a dentist, or a podiatrist. I needed a podiatrist to be my collaborating physician for my psychiatric work, as long as I had somebody. And then they moved to independent practice if you had a certain number of hours. So you had to have 2,000 hours and 2 years. It wasn't either or, you had to have both. So 2,000 hours and 2 years of clinical practice. That has since been removed, and Delaware is now completely a full practice state. So, nurse practitioners can practice at, their full scope, and have, just from the door, be able to practice without having to work with a collaborator or have someone sign off on their hours. I think I saw a question in the back, Dr. Bradley.
Yeah, Pat Bradley. I just wanted to ask if the physicians can charge whatever they want.
Yes.
Yes.
Or is there a range, or is there
Anything's negotiable, and they know that. So they know that power that they have over us. So think about it. We have our private practice, we have our collaborator. If they feel like saying, I don't want to be your collaborator anymore, well, what are we going to do? We're running a business. So you always have to, I'm always thinking ahead. So if this doctor decides that they don't want to sign my paper, who's my runner-up? Where can I find another doctor? What websites are there? What new companies are out there that are now off? Because this has now become a business for them. Absolutely. They're making money. Mm-hmm. They're not really doing anything. We know what we know, and we know what we're doing. But if I had a question, I could call Dr. Josey.
I will say that there's another piece to it. So it's not always a fee financially. So I want to add that component because I have built a relationship with physicians and one of the practice that I worked in when I was working in an integrative care setting. So it's funny because I'm like, there's a few different practices I didn't list in that long list of places I've been. And so what I used to do so that they would be my collaborative physician is that I would cover their practice when they were out of town. In exchange for them being my collaborative physician. So there are ways, there's things that you can negotiate, right? So they would go out of town maybe 4 times a year, And I would go in and cover their charts and review things and answer questions in their practice while they were gone. And there was no money exchanged, it was just that coverage.
Okay. Thank you. Hi, Elizabeth Files. This situation angers me. So who is working on behalf of NPs in this country to go and be your advocate in state legislatures to change this garbage?
Yeah. So there's a couple of different things happening, right? So, sorry. I just forget. I wander. So there are different things happening, right? So people being involved and engaged in their professional organizations, right, and your state nursing organizations.
Right.
So, for example, American Nurses Association we have the American Nurses Association, but then each state has their own chapter. The American Association of Nurse Practitioners has their lobbying and their political action committee. So making sure that people understand that these are the priorities for the health of, their constituents, and then making sure that your state representatives, your state legislatures, those people recognize that this is important to the health of their constituents. I'm fortunate that our lieutenant governor in the state of Delaware is a nurse, and one of our state reps is also a nurse. So when we had to fight with one of the insurance companies that wanted to cut our reimbursement rates by 15% without telling us, they just simply decided, oh, it's a new year and we're cutting your rates because you have, nobody could answer the question. It was just, you have less overhead. And it was like, why? And it was like, because we're independent, they felt like we had less overhead because we didn't have to pay collaborating physicians. So they felt like they could cut our rates. Absolutely not. And we all got on a Zoom call with we got on a Zoom call with the insurance company, and we were called disrespectful because we were continuing to ask the question as to why we were not given this information. And it was a provider forum, so we had a space to be there, we had a right to be there. And I guess the person running the call just didn't pay attention to who was in the audience, because you don't call the lieutenant governor disrespectful or the state rep disrespectful, and that insurance company had to retract their policy and back pay us everything that we were owed. Everything that they cut. But that was involvement with state legislatures through our professional organizations, and as we've heard, having nurses in elected positions. I think we saw a question back there.
Hi, I'm Lara. I just wanted to add to what Dr. Dawn said. I live in Baltimore, but I practice in California, and so I've been active in practice out there for 6 years now. So I've been going through the transition of the newer legislature that has gotten rid of this collaborative agreement, and so it's been a messy process. And so far, what it has looked like. So in my example, I've done, I don't count my hours, but I think in 6 years of work as a practitioner in the community, I must have accrued by now 10,000 to 12,000 clinical hours. They're not counting those, so there's a separate application that we now have to fill out to fulfill the 3,000 hours of clinical practice to receive independent practice, so it's not retroactive. And there's a separate fee for that application as well. And then the newest horrible news coming from California is that they're only accepting applications for licenses that have an active practice exam. So for example, adult psychiatric mental health nurse practitioners, that certification is no longer offered, right? Some of us took the family, which covers all lifespan ages, right? But the adult psychiatric nurse practitioners who took that exam through the ANCC years ago, who have been licensed in California, will not be able to apply for independent practice. They will have to retest in an active certification. So this just came out in the last month, and this is in California. So I think there's a lot of work to do. I have a collaborating position in California, but I have my own panel. I work in a safety net area where I am the only psychiatric nurse practitioner in my county. So it's not like when I have hard, complex patients, I send them off to a psychiatrist. They're my patients. It's my panel. Like it's so these are just rules that can feel like they get in the way sometimes, and even in a place like California where, I remember when the legislation came out, it was like, great news, this is happening, but now we're going through it and it's a mess, and I don't know who's advocating for us.
I was going to say that a lot of schools, a lot of the states.
Dr. Coombs, introduce yourself.
Oh, I'm Dr. Teresa Combs, and I'm on the I'm on the NAC, and I was a fellow years ago. So what I wanted to say is that a lot of the states have physicians on their boards, and that impacts how the agreements that are drawn up and agreed to, and it's really strange that the nurses would have physicians on our boards.
Mm-hmm.
We don't have a position on our board. When you say that would be Nevada.
The Board of Nursing
The board of nursing.
or Division of Professional Regulation in places like that, yeah.
Hello, everybody. I'm Trisha. Taking it a little bit away from what we're discussing, as we're talking about full practice, right? What would you say are tips that you have for when you are ready to start your own practice? So I know, Dr. Josey, you said that Delaware stipulated like a 2-year practice time.
That was before.
Before.
Not now.
But after we graduate, how would you say, like, when would you know that it's time or you're ready?
So I'm not going to not answer that question. What I'm going to say is that we have, we're planning in part 2 to go through a lot of those discussions. So this is more just practical next steps moving into licensure and credentialing and things like that. But we will be talking about that. So if you could just hold that, we will come back to it. Thank you.
Hi, everyone. I'm Nina. I heard a lot of you mention that you practice in multiple states. Does the collaborating physician have to be in the state that you're practicing, or
Can it be another state?
They have to be licensed.
you have to be in the state that you're practicing?
I didn't hear that.
They have to be licensed. So wherever you're, like Pennsylvania, if Dr. Lara is working with a collaborating physician, both physicians have to be licensed in Pennsylvania. I've had some folks say, I was going to retire, but I'll keep my license active if you want to pay for it. Like if I wanted to pay to keep their license active. And if I wanted to pay their malpractice insurance for the extra liability of taking on a nurse practitioner. Because this is the information, whether it's true or not, this is the information, unfortunately, that a lot of our physician colleagues are being fed by places like the PPP. I don't even want to talk them up because something will show up from them later. But they're basically telling doctors, one, don't collaborate with NPs or PAs because it increases your liability. Do you want to be responsible if this person messes up and you're collaborating for them? So if you are going to collaborate, make sure you charge them. Get your liability insurance covered. Make them pay for your license. Make them pay for your DEA, like that type of stuff.
Wow.
Those are the types of things that physicians are being told to do in order to be collaborators for us. And I wish I were making it up, but I'm not. There's no reason for me to make it up because it happens. Yes, Teresa.
So I was gonna say, even though that happens, who's got the mic?
Sorry, she's next
Okay.
then out.
Okay.
Sorry,
Yeah,
I'm Unique. MSN fellow, just graduated from Duke. I was just backtracking to legislature. I was up on the Hill last weekend with ANA at the General Assembly, and they are reintroducing the I CAN Act, increasing care access to nurses. And we were kind of lobbying for that last weekend, and that's to eliminate this barrier on a national level. So it's something that we're reintroducing immediately after the American Medical Association released a statement that they are not for it. So it's already receiving pushback, but it's something that is being reintroduced and something that we can kind of advocate for to our individual states if you guys have opportunities. It's the I CAN Act.
And might I add, this is the time to do so after the pandemic in terms of the way that nurses showed up and continue to provide care during the pandemic. And so if there's any time to be reintroducing that act on a national level, I think now is the time.
So I was just going to say that if even though physicians say that that we have to be that their license is somewhat threatened when they take us on, the regs are very clear that it's not. It's not at all. So it's not true what the information they're releasing to the public.
And the only other thing I would just add about it is that this independent practice will continue to be a challenge, not just at the legislative level, at the state level, but also at a reimbursement level, right? Because even though a state can say we have independent practice, an insurance company can say, I'm not paneling you unless you have a collaborator. I want to know who your collaborator is, and your collaborator has to be paneled with us as well. So every time it can feel like, and I'm just saying it, like every time it feels like we take a step forward, sometimes it feels like another obstacle comes in the way. You know what? No.
We're nurses.
No. We move them out of the way, or we find ways around, or we do something different. It's part of the reason I do martial arts. I kick stuff out of the way. I'm a little like the sidekick, right? Like, they're like, no, this is going out of the way. I will not be stopped this way, and I'm going to do what I need to do. So, there are ways that we move forward, but you move forward understanding we know family systems. It's not just family systems, it's family and organizational systems. Understand the system, know how to operate in it, know the roles that people play and how to work through it and around it and make it work to your advantage.
And collect data.
Give them facts, give them research, give them proof, right? And the proof is in your patient outcomes too. Look how well the patients are doing. Look how long we've had to manage somebody and keep them out of the hospital. How long have we kept them stable in order to, keep them active in their community and working towards their recovery, whether that's from a mental health or substance use issue. We definitely have ways to keep this going. I'm just being mindful of time, so I'm just going to go a little bit to the next slide. Just from a legislative standpoint, as you're moving forward, you've passed your test, you figured out what state you're going to get licensed in, you're getting your license, and then it's like, oh yeah, about that, your DEA. Your DEA is tied to your state license. Even though it's a federal thing, if you're practicing in multiple states, you need multiple DEAs. I don't have an answer as to why, other than they get to collect almost $900 more from you each state, right? So every state where you're prescribing controlled substances, you need to have a DEA number. And that's about $900 for 3 years. One of the things that is important to be mindful of, especially in this time of telehealth and the transition back from telehealth, regulations that were put in place that required in-person visits in order to prescribe controlled substances are changing, and they're being rolled back. So you need to be mindful of that if you're thinking about your telehealth positions and things like that, where if you were going to prescribe a controlled substance, would you have the ability to see somebody in person if you needed to?
if somebody is out of state and in a different state, is there somebody in that other state that's going to be able to see that person for that, at least that one visit in person that they need to have? And you also need to keep in mind that even though the feds have their rules about controlled substances, each state will have its own rules, right? So you get your license, you're getting your DEA, but then New Jersey wants how many hours of controlled substance? 6 hours, right? So after all that, you've done your psychopharm, you've done everything, you've got a license. In order to get your controlled substance registration, you need to now have 6 hours of controlled substance education. Pennsylvania, you've got to do something different. Delaware, you've got to do something different. So it's important to go on the state's website, look at the application, and understand that there's different steps for each thing that you're going to do.
Can I add one thing that I learned working for the state at the University of California is actually there are some states, if you work for a state institution, will pay for your DEA, and then you can only use that DEA for that specific practice. But it was wonderful to find out that they were going to pay for it.
Right.
So just FYI, keep that in mind because it was out of pocket in Illinois, and I got to UC, and they said, "Oh, for our practice, we will pay for your DEA."
Yep. But you can't use it anywhere
But
else.
you can't use it anywhere else. Just with us.
Yeah. So as we get ready to take our we're gonna take our personal care break or personal needs break. But as we're prepping and getting ready for part 2, thinking about, you're prepping for your exam, so you're reviewing your test content outline or taking your review course, whatever you need to do. Some of you have already passed your exams, and congratulations to you for doing that. Yes. But also thinking about where you're going for practice. So where are you going to be most comfortable? Where do you feel most comfortable? Where do you feel the least comfortable? What makes you the most terrified? If I had to go work in XYZ place, or if I had to work with XYZ population, I'm not going to feel okay. You need to know that about yourself because you're going to carry all of that with you into your practice. And so you need to be comfortable going into your practice. And also being mindful of what support you might need in your transition to practice. So whether it's your first year, second year, third year, transitioning into academia, or what kind of support, what kind of help do you feel like you need? So when we come back, we're going to talk about a variety of settings. We're going to talk about things, and these are some of the things that we thought you guys would have questions. And as we got the questions, we were like, right on the money. But so we want to think about physiological, psychological safety in any location where we are. Things about licensure, liability insurance, all these interview and contract negotiation things. So we'll be coming back to this. If you have questions about any of this stuff or anything else, please make sure to keep them in mind so that we can talk about them. And I'll say we'll take a 10-minute. Yes, go ahead. Sorry, David. I'm like, nah.
So, one thing for those of you that are still preparing for board, please contact me. I have some really awesome materials that will really help you. So that's one. One other thing that I wanted to chip in, or kind of, is a comment / question. When we think about the national level of what we're talking about in full practice, would it be more strategic as we are thinking about this to put everybody's skin in the game? There are 4.2 million nurses in this country. If we can put their skin in the game in this bill, right? Thinking about nursing reimbursement, bedside nursing reimbursement, we are the only licensed clinician that cannot charge for the services that we provide, right? Even respiratory therapists bill for their service. Our services is attached to janitorial staff, bed, and all those things. If we can have nurses put it, because if I'm a registered nurse today, what is my, and I don't intend on going to advanced practice nursing, what do I care? Right? What self-interest? Everybody is designed to pursue their self-interest. So that's something I'm thinking about in terms of how we move forward in this bill, both at the state level, also at the national level. Another thing that I want to ask is this: when we talk about board of nursing, a lot of us are not involved. And I looked at, I just moved to Pennsylvania, and I looked at their board of nursing because I was trying to get licensed there. I was like, this is, yeah. But I was like, if you had the impetus to put this on your board website, what do you have at the back? So how do we encourage nurses, and how do we think about getting them the skill set and the tools to sit at the table? Because if you're not at the table, you're a full course meal. And unfortunately, we are usually the full course meal. So that's question / comment. Thank you.
We'll come to it after we take our break and we'll come back.
Thank you, everyone.
Yeah.